It's almost 1 o'clock now. Should we start?
Yeah, sure.
Great. Thank you so much.
Right.
So very good afternoon to everybody in India and a good day to everybody around the globe. I am Dr. Amit Borse and I'm a marketing head for MCure division of IVF, IVA. We are on a mission of nurturing 28 days. Programming 28 is a scientific theme for the year and is based on the concept of managing an ovarian cycle with different gonadotropins, analogs, and hormones. Here we are today again with our 5th in series, International Icons of IVF. We are very glad to have a wonderful response around the globe. We are thankful to Dr. Rajan Vaidya sir and Dr. Meenakshi Chaudhary ma'am for helping us out to host this event and to conceptualize and deliver wonderful sessions one after the other with fantastic speakers. Today we have with us Professor Dr. Cindy Farquhar from New Zealand. Before we go ahead, may I request Nikhil Mehra sir to say a few words.
Thank you, Dr. Amit. Very warm Sunday good afternoon to everyone out over here in India and to the other viewers from New Zealand, very warm Sunday evening, and to other part of the world, it's good morning and good day. So we are glad to have this next series of International Icons of IVF, where we have a speaker, Professor Cindy Farquhar, and our beloved host, Dr. Rajan Vaidya sir, and our co-host, ma'am, Meenakshi Chaudhary ma'am. So thank you so much for, initiating this wonderful event. Just to say a few words about MCure. So as you all know, MCure is the leading organization here in India, and we are among top 10 pharmaceutical company in India and number 1 in the field of gynecologicals. When we talk about IVF, we are the most preferred IVF partners in India. So thank you all the viewers for being a part of this wonderful webinar. Over to you, Dr. Amit. Thank you.
Thank you so much, Nikhil Mehra sir. Go ahead. I would like to briefly describe our host and co-host. Our host, Dr. Rajan Vaidya sir, is an honorary consultant department of Assisted Reproduction, Nauroz Jivadia IVF Center, Parel, Mumbai. He has been an international and national faculty at ART conferences and has his own center at Kalyan. We also have with us Dr. Meenakshi Chaudhary ma'am. She is a senior consultant in reproductive medicine, Newcastle Fertility Center at Life New Care Hospitals, NHS Trust, UK. She is lead for mitochondrial and egg donation program, research lead as UK regulatory body, HFEA, personal responsible, many other affiliations, and a great academic brief is available for her on the screen. Welcome, ma'am. Today we have Dr. Professor Cindy, and may I now request Dr. Rajan Vaidya sir to please take over the mic and continue with the session.
Thanks, Dr. Amit and Mr. Nikhil Mehra. At the outset, let me wish good evening to our viewers in New Zealand, good morning to viewers in Europe, and good day to our viewers in other parts of the world. Friends, as the quest for higher and higher success rates and lesser complications and failures after IVF continues, many of the currently deployed practices by individual IVF clinics have still not yet been ratified as standard of care treatments. Therefore, we thought of inviting a very eminent personality in the science of assisted reproduction techniques, Professor Cindy Farquhar, to speak about embracing evidence-based IVF practice and what is the Cochrane's perspective about it. Professor Cindy Farquhar is a fellow of Royal College of Obstetricians and Gynecologists of London, United Kingdom, fellow of Royal Australian and New Zealand College of Obstetricians and Gynecologists, Professor of Obstetrics and Gynecology, National University Hospital, Auckland, New Zealand, Clinical Director, Department of Fertility at the National Women's Hospital, Auckland, New Zealand, Co-Chair, Cochrane Governing Board, Coordinating Editor, Cochrane Gynecology and Fertility Division, and Dean, Royal Australian College of Obstetricians and Gynecologists. So dear all, we have a very eminent, revered faculty in this field of assisted reproduction techniques, who herself is a governing chair of Cochrane Governing Board. And who better could we have had for having a Cochrane's perspective on embracing evidence-based IVF practice. With this small introduction of Professor Cindy Farquhar, I would now request her presentation to be started.
Thank you, sir.
Dr. Amit, please.
Yes.
So, good afternoon, everybody. My name is Cindy Farquhar, and I'm from the University of Auckland and Fertility Plus, also in Auckland, New Zealand. And I've been asked to speak to you this afternoon about embracing evidence-based IVF practice and a Cochrane perspective. So I don't have any commercial conflicts of interest, and the views expressed here are my own and not those of the Cochrane Collaboration or the University of Auckland or Fertility Plus. So to turn to the topic of evidence-based medicine, these will be familiar to you, I'm sure. And the yellow circle is clinical judgment, and the red circle is relevant scientific evidence. And this comes from randomized controlled trials and systematic reviews. And effectiveness is usually what we want to establish. And the question is, does this treatment increase live birth rates? And there's usually a safety aspect to it. Does this treatment carry any risks? And then in the blue circle, we have patient values and preferences. And these are the rights and values and preferences of patients. And this is where we have shared decision-making and informed consent. So when we recommend treatments, we need to have high-quality research. And this means randomized controlled trials where neither the patient nor the doctor will know if the patient will receive the treatment or a placebo or usual care. And the study must be large enough to meet statistical significance. And studies of less than 100 will rarely be enough to show benefit, let alone harms. And we would hope that the benefits will outweigh the negative effects, that that the research will be published in peer-reviewed journals, and then that we will have a way of applying the evidence. We consider, does this study apply to our patients, the data and safety, is it worth it, and can we afford it? And this little figure here shows you what a randomized controlled trial is. All the same group of patients, but randomly assigned to treatment or control group and a follow-up period, and then we compare the results. Unfortunately for us, the quality of infertility studies is lacking. And in fact, I'd consider that it's quite shameful when you consider the global efforts for fertility research and how important it is. This paper, published in British Journal of ONG, Reproductive Medicine, still more art than science, highlighted the problems of low prospective registration of the clinical trials, inadequate randomizational power, inexplicable or unlikely large benefits, and poor reporting of outcomes. So we want randomized controlled trials, but not just randomized controlled trials. We really want to think about systematic reviews. And a systematic review is a summary of all the available studies. It's generally or often restricted to randomized controlled trials only. And the results of individual studies can then be combined in a meta-analysis to give an overall result. And systematic reviews should also include a critical appraisal of the quality of the included studies. So here's a little example of what happens and how you write a systematic review: identifying the issue, write a plan, search for the studies, and there'll be different types of studies, sift and select the studies, extract the data from the studies, assess the quality, combine the data, discuss and conclude overall findings, and then publish the systematic review and the dissemination of it. And so this is where we come up with this concept of a body of evidence. It's a systematic review of all the available high-quality studies that have been carefully scrutinized. Now, to turn to infertility, well, we know it's common and that treatment success is not guaranteed and is really at times extremely disappointing. Fewer than half of women conceive after one completed cycle of IVF. And these are high stakes where patients will either gain or lose a great deal, depending on a number of factors, including the treatments that they may be offered. There's only a time-limited window of opportunity for couples to conceive. And as you know, women start to have reduced fertility really from their mid-30s onwards, and certainly a much steeper decline as they approach 40. And that the burden of treatment in IVF is moderate. And what do I mean by that? Is that it's invasive, it takes time, and sometimes it's uncomfortable, and it's also costly. And most treatments around the world are not fully funded. And even in countries where there's socialized medicine, such as New Zealand, there may be additional payments, or few people may actually be able to access, or I should just rephrase that, not all women can access IVF treatment in New Zealand. And so our patients, you could say, are between a rock and a hard place. Where do they go? They want to, they recognize that they need to get on and try and be pregnant in their 30s, but the treatments are expensive and they can't afford it. And so we all want more out of fertility treatments. And this is data from the Australian and New Zealand database for ART, and it's known as ANZARD. And here are the live births from fresh and thaw cycles per egg collection. So for each egg collection, they've followed up the proportion of women who've become pregnant. It's not quite a cumulative live birth rate, but a combination of the transfers. And this is over 5 years, and you can see in 2014, it was 32.8%. So 1 in 3 couples, when they've used all of their eggs, embryos from a given cycle. And it really hasn't greatly improved over those 5 years. And here we are with 33.9%. So this demand for good results has led to a culture of this demand for better results has led to a culture of good ideas. And this may be familiar to you. And we have a challenge of meeting our patients' needs. We want to offer them the best treatments. There's competing knowledge sources. We have medical journals with single studies and reviews. We have medical societies with statements and guidelines. We have conferences, we have industry information, and we have our colleagues who will offer advice. And it's also a challenge for us to be part of a clinical system, a clinical health service, such as a fertility clinic, to be sustainable and to have economic survival. And in a public health service, there are pressures on us to spend the money in other ways. And if you're a commercial clinic, then you've also got sustainability issues as well. And so sometimes it feels like we're rowing a boat in 2 different directions. Here we want to meet our patients' needs, but at the same time we have to survive economically. So there have been a lot of good ideas suggested over the years in our specialty, and I'll just give you a few examples from the general ONG. You'll remember thalidomide. Well, no, you hopefully don't remember thalidomide for nausea in early pregnancy, but you will have heard of it. Diethylstilbestrol for recurrent miscarriage. Both of these treatments were disastrous for the offspring of children born. There was a phase when we routinely were recommending removing ovaries at the time of hysterectomy. Some of you may recall the Dalcon Shield for intrauterine contraception, which caused devastating pelvic disease. And in the fertility world, we've even got some more good ideas. You might have heard of zygote or gamete intrafallopian transfer, subzonal insemination, danazol for infertility, scoring systems for pronucleate embryos, and most add-ons would fall into that category of some good ideas, but not much to show for its effectiveness. So I just really also want to say at the same time, I do recognise that you don't need an RCT for everything. And here are some examples from the last century, really. Insulin's been around now for 100 years, which is remarkable. Insulin for almost 100 years. Insulin for ketoacidosis, penicillin for bronchopneumonia, resuscitation for cardiovascular collapse, and IVF for tubal infertility. I think we can accept that if the fallopian tubes are blocked and IVF can overcome that blockage, we don't need to have a randomized controlled trial for tubal infertility. But yes, we do need it for all sorts of other infertility caused by other conditions. So we generally say that we need RCTs for areas where there's uncertainty or where the effects of healthcare are small. And in the examples that I've got up here, this is really, all of these have been what we'd say game changers in the day that they were introduced. And we are really very fortunate to have lived through an era where we have access to these interventions. So clinical trials are the building blocks of evidence-based medicine. And you've heard about this already from me today. And they're the building blocks for systematic reviews and for guidelines. And I've worked for the last 25 years with the Cochrane collaboration. I hope you're familiar with it. I'll just summarize briefly. It's an international group of trained researchers, and we consider that we're producing the highest quality systematic reviews. We use a robust methodology, reliable results, and we do critical appraisal of the included studies. And we're independent with, we don't receive funding from commercial organizations. And this is the Cochrane logo, and it's a meta-analysis, and you can find out more about the Cochrane Library here. So this is about a body of evidence where a systematic review of all available high-quality studies has been carefully scrutinized within a Cochrane review. So systematic reviews are important because they reduce bias. We have pre-stated methods and a published protocol. We do a comprehensive search for searching for and including unpublished studies, which used to be quite unique. Now I think it's more common. We don't apply any language restrictions, and we have independent reviewers. So they should be independent. Two independent reviewers will look at the inclusion criteria, assess the studies for risk of bias, and do the data entry and analysis. Now, this is the current front page of the Cochrane Gynecology and Fertility Group, the group that I lead. And you can find this on the Cochrane Library under the button called Groups, or you can just put the words in, and hopefully it will take you to this home page. And you can see that we've got a section on fertility and pregnancy at the moment, where you can find a lot of resources about COVID-19 in that area. We've also done a priority setting exercise for Cochrane and fertility reviews. We have take part in various awareness events, and so Polycystic Syndrome Awareness Month. And there's another one coming up, which is, I think it's just been hormone replacement therapy. We do some masterclasses in teaching Cochrane methodology, and here's an update on a new Cochrane review. So we have a register of clinical trials for fertility treatments, and we also have one for gynecology. And we have also 136 systematic reviews on fertility topics. and 48 are new or updated reviews in the past 2 years. And for assisted reproduction, there are 78 reviews and 19 of them are on add-ons. Now, these are the topics. We've grouped them in: assisted conception, male subfertility, female subfertility, and unexplained and others. And the green bars here are the updated ones. So we now have more updated reviews than new reviews. And the red bars here are new ones, and then the blue ones are protocols. And we also have in the Cochrane Library a special collection at the moment called In Vitro Fertilization Effectiveness of Add-ons, where you can find these 19 reviews and an explanation of them. Oh, sorry, there's a great bit more information here. And we've grouped them into laboratory add-ons, clinical add-ons, and add-ons for the endometrium. So I think we should acknowledge that EBM is not perfect. It requires understanding, practice, and skill, and that we need to address whether EBM is even feasible in some settings and with some conditions. We know that trials are costly and take time, but I still consider that it's better value than getting it wrong, and that evidence alone is not sufficient, and we've mentioned that already. We need clinical judgments and the patient values. So I just want to turn now to trying to use EBM every day in the fertility clinic. And it is more difficult than we think. Sometimes it's easier just to keep on the track that we've always been on. So I'm just going to cover these 5 topics. And some of them have got Cochrane evidence and some of them have got other evidence. So we'll work our way through them. So the first one we'll turn to shortly is elective single embryo transfer. So I've got the intervention here in this column, and then we've got the grade of evidence, moderate quality or not, and then we've got the global uptake. What are people doing about single embryo transfer? And I'll talk about that. And then I'd ask you the question now: what do you do in your clinic? And if you were in the room with me here, I'd say, who's got 80% single embryo transfer, and see what people say, but or higher. But I can't do that today, but I want you to give some consideration. So this is about single embryo transfers, and this is just to highlight, I don't want to go into the details of why twins are so challenging for people and for healthcare in particular. But this just mentions that, twins do create their own special problems, and in particular with increased rates of miscarriage and perinatal mortality. It is something to be avoided. So we have a Cochrane review on this topic, and it's this is a review actually done led by one of your colleagues in the law, in this review, it shows that the cumulative live birth rate is similar with repeated elective single embryo transfer and with the double embryo transfer. And this is moderate quality. So the implication of this is that if the two are similar, then we should choose the elective single embryo transfer because of the reduced rates of multiple pregnancy. And here is the meta-analysis graph here. We've got a few studies there, not very many, I agree, but the overall numbers are good. 434 in this arm and 444 here. And so this is one single embryo transfer, a fresh and a frozen, versus 2 single embryo transfers, and these are at cleavage stage. And this is a similar comparison, except that there were single embryo transfers each one was a different single embryo transfer and didn't include a frozen versus double embryo transfer. And you can see the results don't show any increase in don't show any difference between the two arms that are in the study, and would suggest that you can be very happy with your live birth rates if you transfer one at a time, but you must count them as a cumulative live birth rate. So the uptake of elective single embryo transfer has been steady, and in most parts of the world, it's looking pretty good. So these are the and had the desired effect. So these are the multiple pregnancy rates here on this graph here. And so Australia and New Zealand here had started to do elective single embryo transfer quite early on. And so even in 2004, they had only 15% multiple pregnancies, whereas some countries 10 years later are just getting to that level. So, and now in Australia and New Zealand, it's under 5%, and in our own clinic, it is around 1 to 2%. And we're very happy with that, and our neonatal intensive care specialists are very happy with it as well. And you can see some other countries here. Here's the UK, and they have now got down to under 15%, but they're still above the 10% mark. Here is the USA's the green one, still in the 20s, and here's Latin America, also still in the 20s. Now, I don't know what rates are in India, but I know that there is a lot of pressure on people to put back 2 embryos, and it may be that your rates are still somewhere around 15%. I don't know. So the role of funding this is important, and this is where really values come into it, because if you don't have to pay for each of those embryo transfers or egg collections and embryo transfers, then it's relatively easy to have one fresh embryo or a frozen embryo to be transferred one at a time. But if you want to save money and you don't want to have to come back for a separate embryo transfer, then patients may feel under pressure to have the 2 embryos put back because of their own personal finances. And this paper by Chambers from Australia, she's shown in Australia, New Zealand, and Nordic countries, they're all reporting less than 5% multiples, and they all, go backwards. Oh, I've gone on ahead. I won't be a moment. I'm just going to go backwards. Sorry. And so they've all back to here. So in these countries, they all receive funding for fertility treatments, and that may allow this to these lower rates. So I think governments have a lot or health authorities have a lot to do with making this better. All right, so just to finish this off, the evidence suggests what's the right thing to do. What is your rate? And as I've said, New Zealand funding means that we have to that we're funded to do it. Now to turn to freeze-all cycles, and we have a Cochrane review on this topic. Fresh versus frozen embryo transfers. And again, this shows no clear evidence of a difference in cumulative live birth rates between the freeze-all strategy and the conventional IVF-ICSI strategy. This was quite a lot of women, nearly 2,000 women, moderate quality evidence, and doesn't show any benefit in one direction or the other. And there's also been a similar review in Human Reproduction shortly after this one was published in 2000. And in this one, it says in normo responders, there was no difference in live birth rate. So fairly similar results. And overall, that there was no benefit for women other than for those at risk of an exaggerated ovarian response. However, and then a further randomized controlled trial came out last year, and this one is from Denmark, and it shows all women with regular menstrual cycles, and women with regular menstrual cycles, a freeze-all strategy with agonist triggering did not result in higher ongoing pregnancies and live birth rates in a fresh transfer with HCG triggering, but it did show longer time to treatment in the freeze-all group. So all of this is leading to the concept that elective freezing is not a necessary add-on. This comes from the HFEA in the UK, the Human Fertilisation Embryology Authority, and they've given elective freeze-all cycles in amber to say it's rated amber, which means that there's no convincing evidence that we should go ahead with it. Yet freezing all is increasingly being used. In the UK, it did decrease by 11%. Fresh embryo transfers decreased by 11% over 5 years, while frozen embryo transfers have almost doubled. So 38% of all IVF cycles in 2018 were freeze-all. And in the US, 25% of all cycles were frozen in 2016. And in Australia and New Zealand, it's 27% of all cycles. Our clinic is 30% currently. So with this new evidence, I think we can confidently offer fresh transfers to women who do not have risk factors for over-response. Now I want to turn to the endometrial receptivity analysis. This is known as, sometimes known as ERA. It's also known as a personalized blastocyst transfer or personalized embryo transfer. And I personally haven't used it, but there are some patients in our clinic who've paid for it to be used. So I don't know a lot about it. I know that it's optimizing the window of implantation by adjusting the time of embryo transfer according to the results from the previous cycle. So we have here, this is a study, it was published in September 2020. And here are the results along the bottom. So it's cumulative live birth rate here. And this is the personalized embryo transfer, and this is just the frozen embryo transfer, and this is the fresh embryo transfer. And you can see the numbers was randomized controlled trial. They didn't include patients who'd had more than 2 failed embryo transfers. So these were really a low risk population. And the cumulative live birth rates in the study were for the personalized embryo transfers, 62%, for the frozen embryo transfers, 55%, and for the fresh embryo transfers, 58%. And I'll just highlight that. And then this is comparing the results of the personalized embryo transfers with the results with the frozen embryo transfers. And you can see here that that the relative risk is 1.13 and the wider confidence intervals, and there's the p-value. And the same with the personalized embryo transfers versus fresh embryo transfers. It didn't show any, there's no evidence that it was more effective to do one treatment or the other. Yet, slightly out of order, sorry. in spite of the lack of evidence, this is being offered by many clinics in the UK and in Australia and New Zealand. And and this is the cost from one of the clinics in the UK. So it's really, I think that's quite expensive, £1,500. And I think that we really need further studies in women with recurrent implantation, which is really the group we want to help to try and improve their outcomes. We don't offer it in Auckland, but I did just say to you that sometimes patients have asked for it. And so I think we've done it on a couple of occasions. And it does involve us sending samples outside of the country, so it's quite involved. So now to turn to endometrial scratching. A definition of a scratch is to score or mark the surface of something with a sharp or pointed object. And when I think of scratching, I always think of a cat and how they scratch. So it's not really a term I like, endometrial scratching, but it's certainly become very commonly used. It's not a scratch really, but it's an endometrial injury. And so you'll see that that's what our Cochrane review says. But this is an article that we wrote in the Human Reproduction in 2015 when we did a survey of clinicians. 83% of clinicians were offering the procedure to their patients. 92% reported repeated implantation failure as an indication. The cost isn't huge compared to the cost of an IVF cycle, but $150 up to $750. We've done, we had a Cochrane review on this in 2015, and it's said, although current evidence suggests some benefit, we need evidence from well-designed trials that would avoid instrumentation in the uterus in the preceding month, stratify the results for women with and without implantation, and report live birth. And so this is from the Cochrane review. You can see that if you'd had less than one or fewer previous embryo transfers, then there was no evidence of a benefit. There was some suggestion of benefit if there's greater than 2 previous embryo transfers. So this is the idea that came through, that there might be benefit for women with recurrent implantation failure. And then for unselected population, where we didn't know, there didn't seem to be any benefit. But all of these, this data, we were concerned because of the high risk of bias with unpublished studies and abstracts, interim analyses, and unclear randomization allocation tables, and confounding from having concurrent disruptive procedures. So we did a PIP study, and I'll just show you, these are the centres. It was led from New Zealand, but we had Australia, Sweden, the UK, and Belgium helping us recruit. So 13 centres, and this was subsequently published in the New England Journal of Medicine, and I'll just very briefly show you the results. So this is the live birth data. The woman who had a scratch had a live birth rate of, or proportion was 26.1%. The control group was 26.1%. The odds ratio was 1, and really no evidence of a benefit was reported. And we looked at subgroup analyses, such as recurrent implantation failure, and we didn't find any evidence of an effect. And we looked at fresh and frozen, and we didn't find any evidence of effect. And and we looked at duration of fertility, non-disruptive instrumentation, and contraceptive pill scheduling, and no evidence. And we didn't identify any subgroup of women who really benefited from the endometrial scratch. So since then, there have been 2 new studies of endometrial scratching, one with one failed IVF cycle. This one was from the Netherlands. Actually, it has now been published. And this one, it was from the UK. It's also been published. and endometrial scratch was found to be of no value to first-time patients. In this, the Met Wiley study, and the investigator says time for this add-on treatment to stop. We have done an update of our Cochrane review, and this is it's here. So the live births, now this is, there are 8 RCTs. The odds ratio is 1.12, but the confidence intervals include 0.98 to 1.2, and clinical pregnancies. The confidence intervals are a bit broader. So both is considered to be moderate evidence, and I'm sorry, I've gone on too far. I guess some people would still say that there may be an effect of endometrial scratching. We personally do not. Our group does not think so. Cochrane group doesn't think so, and we haven't been offering it in our clinic for some time now, outside of the clinical trial. So now to talk about embryo selection, and in particular testing embryos for aneuploidy, PGTA. So it aims to avoid the transfer of aneuploid embryos and improve live birth. Which years ago now, the we now know that is probably other studies and those spices, and also so it is limited which some of these many of these embryos will have, may have reproductive potential, yet they might have been discarded. So we have a Cochrane review on this topic, and this is the summary for the live birth, and it was updated last year. So we've got the group with polar body biopsy, and we've got the group with the blastocyst stage biopsy. We haven't put them together, but as you can see, we didn't pull them because they're 2 different stages of embryo development, but neither of them show any benefit. They're reasonably good studies reasonably large studies. So this was very surprising to some of the people who were doing these studies. And so we'd say that the current available evidence is insufficient to support PGTA in routine clinical practice. Yet we're seeing it, not so much in the UK, it's only 2% and it hasn't changed. In the US, it's gone from 13 to 27%. And you can read about this, the 2 differences really between the UK and the US in this paper here. In Melbourne, Australia, they have also been investigating this using a different type of technology, non-invasive pre-implantation genetic testing. And this is looking at the culture media from spent from embryos. And so this is from their website in 2019. Our in-house studies have demonstrated that non-invasive PGT results are identical to the embryo biopsy PGT result in 95% of the cases. It's important to note that this method is not 100% accurate. They were charging this at $495 per embryo. Now, no publication has come out for this, and so perhaps I can't show you any of the scientific studies about it. But I did know that last year and into this year that patients have been suing about this because of the inaccurate genetic results, and they found out some of their embryos were not actually discarded. So it's a little bit, it's in the courts, and I'm not sure what's gone on, but I just really put this up as an example that this is a rapidly changing field, but we need to get our studies right, and we need to publish the data perhaps before we start offering it. This has caused all sorts of questions about the add-ons that we have. And so I just want to really finish off and talk to you about add-ons, increased scrutiny of add-ons in the UK, in New York, in Australia, and really I think fertility clinics are under greater scrutiny now because of I guess because of our love affair in a way with add-ons. I understand what drives it. We want to improve our clinical pregnancy rates, but we are really sometimes rather enthusiastic about new treatments. So the Human Fertilization and Embryology Authority has a traffic light system. And I mentioned this before, red, amber, green, and I showed you an amber one. And so the red's no evidence, amber is conflicting evidence, and green is there's more than one good RCT that shows the procedure is effective and safe. And this is from 2019. This very well-known professor of amongst other things, embryology, Joyce Harper. She wrote a review of add-ons for human reproduction. We conclude that robust studies are needed to confirm the safety and efficacy of any adjunct treatment or test before they're offered routinely to IVF patients. And there's this table here with the various types of laboratory add-ons: embryo glue and adherence, sperm DNA fragmentation, time-lapse systems, PGS, mitochondria DNA load, and assisted hatching. Now, I haven't got time to go into all of these, but I would just add that you can see the evidence there, and this is a good article to read. And then we've also had a series in fertility and sterility about the ethics of ART add-ons, so this is where mediocre success drives add-ons, which I've talked about. There's little regulation. We need to have informed consent, and we need to provide factual information. And just a little bit from what we're doing locally in Australia and New Zealand. This is a technical bulletin about the use of adjuvants in 2019. And it says here, in order to minimise any risks, ARTAC and the Fertility Society of Australia recommends that all ART units should provide appropriate and accurate information regarding the effectiveness, including the strength of the evidence, and that they should require written informed consent. And so that's what. Oh dear, I'm sorry, I went too far again. And so with regard to this, our clinic does have a consent form now for add-ons, and we ensure that each of the add-ons that we offer, which is fairly limited, embryo glue being one of them, that we are giving patients information about it. So IVF and evidence. Look for evidence from a body of evidence that uses best quality studies. And I mentioned Cochrane, but there are other good systematic reviews as well. And then offer the most effective and safest fertility treatments, particularly trying to avoid the complications of IVF, such as multiple pregnancy and OHSS. So thank you very much, everybody. I've come to the end of my lecture. I just want to acknowledge the Cochrane editors and authors that I work with. And I'm very grateful to, if any of you in the audience have been part of the Cochrane review or been on one of our training courses, I say hello to you and thank you for taking part in this work. And if you wish to get in touch with me, I'm very happy to hear from you. Good night.
Thank you very much, Professor Cindy. That was a wonderful talk on such a very fascinating topic of embracing evidence-based IVF practice. Myself, Dr. Rajan Vaidya from Mumbai, your host from India. And you touched upon very 5 commonly used add-ons in the IVF treatments. I must admit that you put forward the most factual evidence available on these add-ons and your personal opinions on this too. Just to start off the discussion, I would have one question to you, and that is one more add-on that is being very fancifully deployed in India, and that is embryo selection by using time-lapse technology and studying the morphokinetics of the embryo. So what's the evidence suggest, and what's your personal opinion on embryo selection by using time-lapse technology and morphokinetics of the embryo?
Thank you for the question. Yes, I could have put time-lapse in there. And when time-lapse was first introduced, which was about 8 years ago now, I think, the idea was that it would help the embryologist to select the best embryo. The randomized controlled trials have actually shown that embryologists were doing a pretty good job, because when they've been compared with the time-lapse, the results haven't been that different. And there's various algorithms that have been tried, and without perhaps selection of individuals' images, and then the algorithms. But having said that, time-lapse has certainly been widely introduced, and I think there's more than one reason for that, not just about the evidence, but actually the efficiency in the laboratory and the very nice streamlining of the laboratory processes. So I think my own view is that it's obviously a good development, but please don't sell it to your patients as being superior. And if you haven't got it, then I don't think it should make a big difference. And I think also that you shouldn't charge patients for it. It should be part of the overall economic picture of the laboratory. And there's further studies going on in this, and I know there's one in the UK that's coming to an end in the next year, and so we will have more results. The Cochrane review on it doesn't show evidence of benefit, but as I say, it's not to say it wouldn't be a wonderful thing to have if you can afford it.
Thank you very much.
Cindy, thank you so much for a brilliant lecture. It was fascinating hearing from you. As one of the co-authors for Cochrane contributions, I know what an immense resource source that is. I have one simple question for you. I mean, as you know, I practice in the UK, and HFE has come up with this traffic light system, which is very good for signposting our patients to, because it's very simple to understand and look at it like a visual analog. What do you think Cochrane would come up with something like that? Because Cochrane, as you said, they have 9,000 articles, also systematic reviews and all. I think that would be a very simple way of promoting those results, and for ease of understanding, even for signposting the patients. Thank you.
Oh, that's an interesting question. Thank you for that. Well, Cochrane, so one of the things that we try not to do in Cochrane is to be too directive to people, to provide, you'll notice the Cochrane reviews will tell you what the evidence is saying or not saying, or that, whether it's inconclusive, but it won't say you should do this or you should do that. So Cochrane doesn't do recommendations. So that's the next step, that those building blocks I talked about, guidelines would be the next step. So, but it's still a good point that, we could probably be we could be clearer, and people do like traffic lights and color systems. We could be clearer about whether this is a high quality evidence or or not. And I didn't really show you this in the Cochrane reviews, but you can see the colors in the reviews on the quality of the evidence of the individual studies. So you can see that risk of bias in the graphs. And in the language of the abstract, it should be saying in the more recent reviews for the last 8 or so years, whether it's high quality, moderate quality, low or very low quality. So that's our sort of traffic light system, really. But we don't tell you. Generally, we don't tell you what to do. Try not to tell you what to do, but because everybody's got to make up their mind according to the circumstances of their country and their health system and the clinic. So the guideline developers take that evidence and then will make recommendations. And those could be better color-coded too.
Rajan, if it's okay, I'll ask one more question.
I have also had one more, but you can go first.
All right, okay. Cindy, sorry, my name is coming as a different name, but it's Meena here. And thank you for accepting the invite. So I was just going to not ask you, because I know we have got a lot of people listening to us, the delegates who have registered. I've heard there are thousands of delegates who have registered. And they may not be aware, as one of the Cochrane contributor, as a co-author, what I realized that Cochrane offers huge help and support when gathering evidence for systematic reviews and all. And that is available from the Cochrane group. So whether you wanted to highlight that to the rest of the listeners so that if they wanted to come up with a brilliant idea, they could contact Cochrane group and the support and help that is available. Thank you.
So we do, Meena, thank you for that and acknowledging that. We do have an editorial group based, one in Auckland and one in the Netherlands, and we have people who will help with the searching. We do have we talked about the 9,000 trials. We have the hard copies of those. We have them all stored electronically, the full articles. So if you can't find an article, we will send it to you. And we also will provide training and assistance in getting the review over the line. However, we are rather limited in the number of new reviews that we're doing every year. And so you may come up with a bright idea. We will always have to check whether we've already got that review on the library. And then we're reasonably restrictive. I don't know if you found this, Meena, but we want people to be, have the time to do it, be prepared to do the training, take our advice. We're known to be reasonably, it's not an easy thing to do a Cochrane review, and you won't automatically get it accepted at the first round. And I don't know how many rounds you had, Meena, but it's some people complain about this, that we're rather rigid about things, but we're trying to keep to the standards of Cochrane. So
mine is more of a comment and a question at the end, that it's in a welcome sign even in India that many couples are now opting for elective single embryo transfer than what they used to do about a decade and a half ago. They would like to get pregnant at any cost, but now they know that being pregnant is of lesser importance than having a single normal term infant, and that's the reason why they would go for a single embryo transfer. That's the reason. That's a welcome sign. Another thing is, as I could recollect from your slides, that the freezing of the freeze cycles as well as the autologous transfers, there is not much of a difference in the pregnancy rate, or I thought probably I read the autologous transfers lead to slightly higher pregnancy rate. Was that right, or I don't know?
No, well, freeze all, unless they were. I've just got to remind myself what was in it.
I would complete the observation first. The thing is that the freezing has certainly brought down the very ghastly complication of ovarian hyperstimulation syndrome, particularly in high-grade PCO patients. And that's where the freezing would definitely be a little more outscoring over autologous transfers.
And that was exactly that's what came through. Actually, I quoted another review, more recent review than the Cochrane review, which showed that if you were a normo-responsive, not an over-responder, that there was really no benefit in going for a freeze-all. But there'll be some other reasons, we have to report our freeze-all rates to our regulator and provide the reasons. So we're monitoring this, but I think the time to pregnancy is shorter, of course, if you do a fresh transfer, and there's an advantage in that. And there's also a cost in having a freeze-all cycle that's more expensive than going for the fresh. So, so we're trying to keep the proportion down.
Nice answer. Thank you very much. Very good answer. Thank you.
I think it's time to wind up the session, isn't it? It was a brilliant session. 2:00 now.
Absolutely.
Indian time. And thank you so much, Sanjay.
Yeah, well, thank you very much. And I hope you're all in good health, and I hope the rest of the meeting goes well.
Same to you. Okay, thank you very much. It was a wonderful talk.
Okay.
Thank you.
Thank you so much.
Thank you
Thank
so
you,
much.
Thanks.
Thank you so much.
It was fantastic session as always.
Okay. Looks like we again had to ask the questions. No questions from the audience.
Yeah.
I really don't know.
But that was a wonderful talk, a superb talk.
Yes.
I was really engrossed in her talk, and fantastic speaker.
Yeah, I was going to ask one more question about PRP, whether anyone has submitted, because in India, PRP is so commonly used nowadays.
Yes.
And in UK, we don't use it at all because the evidence is not there. And I was going to ask if someone has suggested to look at that in Cochrane. Is there someone looking at it?
That was the question coming up in my mind. I forgot it at the last moment. I wanted to have her take on
I thought
PRP.
about it. Then I looked at the time and I thought maybe we shouldn't keep her waiting so long. So I just left it.
True.
Right. Happy Diwali, and please
Happy
come
Diwali,
over.
Pinakshi, yes. And have a nice celebration at home, and happy Diwali.
Thank you.
Fantastic. Yes.
Thanks,
And Nikhil,
Amit,
Amit, anyone who's planning to come to Jaipur, you're more than welcome. I'll be very happy to receive you.
Ma'am,
I'm
we'll give you
back in
surprise.
Jaipur in a couple of days.
Yes.
So enjoy it, Jaipur, ma'am.
Enjoy
Thank you.
Jaipur. It's
Best
wonderful
wishes.
city. I
Anything
like
from
it.
our side at Jaipur, any assistance, let us know, ma'am.
Oh, I don't know what assistance you could do, but thank you so much for the
anything, because we have a team based out over there. So, any local assistance, any information, any, personal help, please feel free to inform.
Oh, I'm so pleased. Thank you so much. I mean, maybe next time, but I'm doing all right now. But I would love to visit you all in Pune as well one day.
Yeah, and one day in Mumbai too, next time.
Oh, yes, Once my parents come back there, I will be coming over there as well, Rajan.
Sure.
And I'll definitely meet you if you're not in US, because I don't know, you might just be globetrotting to US.
I should be back by 15th of Jan, even if I go to US, because the practice is going on here. I'm planning to spend at least 1.5 months with my children from 1st December to 15th Jan.
All right.
It all depends on the flights operating directly.
Yes.
Yeah. So most probably I will be hosting our next webinar from US, from my son's residence.
Yes, let's hope so. It works well. Take care then.
Thank you.
Bye-bye.
Take care then. Have a nice time with your family.
Thank you, madam.
Thank you. Thank you so much.
We'll be
Thank you, sir.
co-host. Everyone is here.
Yes.
Thanks.
Thanks,
Bye.
Nikhil, and thanks, Dr. Amit and Mr. Kishore, as usual, for taking this series so wonderfully ahead.
Yeah, Kishore is always the silent spectator. He doesn't speak anything. I can always see him in the background.
No, all the experts are here, madam. So I think. So
all of them are very strong music lovers.
All right.
Yeah.
Good.
Thank you so much.
Thank you. Bye-bye.
Thank you so much, madam. Thank you, sir. Thanks a lot, sir.
Bye.
See,
Bye,
all of you
Bye.
have a wonderful Diwali. I hope you all had the wonderful Diwali.
Yeah, thank you. Happy Diwali. Thank you. Thank you.
Bye. Good day. Thank you.
Okay, Nikhil. Okay, Amit and Kishore.